The Joint Committee came together in 1994 and developed the high-risk registry for children with hearing loss. It separated out risk factors for neonates, birth to 28 days, and then infants 29 days to 3 years. They developed a list of indicators for hearing loss, but the list lacked the specificity required to find the majority of children at risk for hearing loss because the majority of children that have hearing loss have a hereditary hearing loss that is of a recessive nature. The people on the Joint Committee were ASHA, the American Academy of Otolaryngology, Head and Neck Surgery, the American Academy of Audiology, and directors of speech and hearing programs in state and welfare agencies. So in 2000, the Joint Committee endorsed the goal of newborn hearing screening, universal newborn hearing screening. By 2000, they came out with objective tests of hearing that were a total game changer. So identification of infants at birth could now be done with this universal newborn hearing screening technique, which we'll talk about. So there are tons of successes with universal newborn hearing screening. Before the universal newborn hearing screening, most infants were not identified with hearing loss until they were about 2 or 3 years old when they hadn't developed language. The test is great, but it's not perfect. There are some infants, it doesn't identify mild hearing loss. Sometimes infants don't come back for follow-up treatments, or sometimes infants might pass their hearing screenings but then have a degenerative hearing loss that comes up later in life. The high-risk registry was maintained for the neonates from birth to 28 days. The infants that fell on this high-risk registry had a family history of congenital or delayed onset childhood sensorineural hearing loss, uterine infections such as rubella or herpes, craniofacial abnormalities, abnormalities of the pinna or the ear canal, low birth weight, less than 3.3 pounds, hyperbilirubinemia, which is excessive amounts of bile in the blood, ototoxic medications, bacterial meningitis, severe depression at birth, a very low APGAR score, prolonged mechanical ventilation, and findings with a syndrome known to include sensorineural or conductive hearing losses. Risk factors from 1 month to 3 years would be parent concern regarding hearing and speech, so you should never discount a parent's concern. If a parent thinks there's a problem, it's definitely worth following up. They spend the most time with their child and know their child best. Bacterial meningitis or other infections associated with sensorineural hearing loss, head trauma, stigmata, or other findings with syndromes, including sensorineural or conductive hearing losses, ototoxic medications, recurrent and persistent otitis media or ear infections for at least 2 months. Infants that pass initial hearing tests but have risk factors require periodic monitoring every 3 to 6 months until the age of 3. Indicators associated with delayed onset of sensorineural hearing loss that might not be identified at birth include a family history of hearing loss, uterine infections, neurofibromatosis, and certain neurodegenerative disorders. Indicators associated with conductive hearing losses include recurrent and persistent ear infections with effusion, that means with fluid, anatomic deformities, and other disorders that affect the eustachian tube dysfunction, and neurodegenerative disorders. ASHA recommends that children at risk for hearing loss undergo ongoing attempts at diagnosis within the first 3 months. This includes parent education, audiological evaluations by auditory brainstem response, which we'll talk about, and comprehensive follow-up and management for those who fail the initial ABR evaluation.